I'm Naveen Malik, and today I am here with Dr. Malik, Director of the Wadley Regional Medical Center's Stroke Program.
Hello. Nice to see you once again.
Good to see you too. So what made you want to be a doctor?
Well, it's kind of an accident, really. When I was a kid, I wanted to fly jets and couldn't fly them because of poor vision. And since I was always somebody who wanted to do something different, so medicine seemed pretty good, especially since my grandfather was also a doctor. So I figured it may be something interesting to do, and decided to go to med school and have had fun ever since.
Okay. What made you pursue neurology?
Well, that was another accident. I actually was doing my what we call a house job in Pakistan, in which you do 6 months of internal medicine and then 6 months of surgery or a different subject. And my dad was sick, so I couldn't do a surgical rotation. So I decided to exchange with a friend of mine who was in neurology. And one day a guy came and he had his face tied up in a turban, holding his face up. And we couldn't figure out what was wrong with him until somebody saw on X-ray some enlarged lymph nodes in his chest. And in Pakistan, in South Asia and that part of the world, usually you think of tuberculosis, but his TB skin test was negative. And somebody came up with the idea, could this be sarcoid? So we started treating this guy with steroids, and within a few days, his facial paralysis was almost gone, and he was able to smile again. And I guess I was hooked.
Interesting. What's your favorite part about being a doctor?
And the favorite part is when people come in with big strokes and they're unable to move or talk or whatever, and then in those cases where we are successful at reversing the stroke, seeing their interaction with their families, how they react, that's fun. How they look at family members. Sometimes they remember what happened, sometimes they don't, but the family members sure do. And the looks on their faces to see that their loved one is again normal or near normal, that's worth it.
Okay. What advice do you have for students who are pursuing the pre-med path?
Well, I guess the advice would be that you really want to be a doctor, and you want to be a doctor for the right reasons. It's not so much about the glamour, the money, or anything else. And I'm not saying that you have to be a saint, but you have to want to see people get better. And I think that's the most important thing, because if it is for anything else, then you usually end up getting frustrated because there are other ways of making money than being a doctor. So if you really want to, then you can do it, and you don't necessarily have to be book smart to be the best physician. You have to care, and you want to be willing to learn and change things. So if you are willing to do that, then medicine is good.
Okay. If you could pursue any other career now, would you? Or if so, what would you pursue?
Well, I don't think I would pursue anything else now. If I had the option, I would probably do another fellowship, doing interventions, yanking out blood clots from people's heads. But that's about it. I think that I'm so far down this career path that wanting to change a career would probably not be an option. Now, if I want to do something post-retirement, I might, but that would be something entirely different, such as raising cows or being a gunsmith.
Interesting. So how frequently do you have to recertify?
Well, We have a 10-year recertification cycle. So every 10 years you have to take a test to recertify, but in between that you have 3 maintenance of certification periods in which you have to do a certain amount of continuing medical education, you have to do some self-assessment tests, and that's a 3-year cycle. So once you've completed 3 of those, then you take the test. So the recertification is every 10 years, but the maintenance of certification are 3-year cycles in between that.
Okay. What exactly do you do? Like, do you own, or do you run a private practice? Do you work for a hospital?
Well, right now I work for a company which owns the hospital. It is set up like a private practice where we see patients in the office, but then I'm also on call, and that of course is after hours and sometimes even during the day. But we see about an average of about 15-16 patients a day, and then and that's about 4.5 days a week. And then when I'm on call, I see whoever comes in through the doors.
Okay.
In the hospital, that is.
So you're on call for how many hours a day?
Well, the day you're on call, so it's not like so many hours, but you're on for the whole day. The difference is that during the day you have between 9 to 5 you have office hours, and then afterwards it's just call. You go make rounds in the hospital, and if you're done, then you're done, and if somebody comes in who needs you, then you have to come back in.
Okay. What are the most common ailments that you see, and how would you diagnose those?
Well, the most common things that we see in this practice are actually strokes, and then of course we see seizures, we see Parkinson's, we see a lot of migraine headaches, especially among younger people. We see some neuromuscular disorders such as myasthenia gravis. But the most common one is strokes, and of course strokes are diagnosed on basically a history, a clinical exam, and then of course imaging. Now, the way we see stroke patients, the majority of those patients are actually seen in the emergency room when they come in case they need to be treated with a clot-busting drug, which is where, as I say, the action is, because you get to see these patients and you can attempt to fix them, especially if they meet specific criteria about who can get those drugs.
Okay. Could you tell us about the acronym used to recognize strokes?
FAST, face, arm, speech, and time. You are looking for a facial droop, arm weakness, speech difficulties, and then time is of the essence. So that's what people need to remember.
Okay. What is one of your most rewarding stories being a doctor?
Being a doctor or treating strokes?
Either.
Well, there are 2 stories then. The first one was actually not as a doctor but as a medical student, when we had a patient who had a rare blood type and had a wreck, fell off a motorcycle, got hit by a brick with a liver laceration, and he was bleeding to death. And at that time we used to run a volunteer blood bank, and we supplied him with blood, first for the initial surgery, and then when a day after surgery he re-bled, we actually had to go to people's homes because his blood type was so rare and get blood from them. And finally the kid survived, and in fact his grandfather came to thank me, and that was rewarding. And as regards strokes, there was a prison guard who was 36 years old who came in on your birthday, had a stroke, and I gave him the clot-busting drug. He was doing well, and I came to see you, and I got called that he's again doing worse. And when I came back, it turned out that for whatever reason he had issues with his heart pump, not pumping well, and he was overloaded with fluid, and somebody had given him diuretic, but it dropped his pressure and he was doing worse. So I had to put him on a BiPAP to blow off his fluid and then put him on some drugs to raise his blood pressure up and get the blood to circulate. And by that evening he was back to normal. That was a good one. As was the 72-year-old Hispanic American who had a stroke after a minor surgery, and we gave him TPA, the clot busting drug, and by that evening he was actually sitting up dialing numbers on his phone, and 2 weeks after that he drove his 18-wheeler to California. So those are the fun ones.
Okay. Well, on an opposite note, who are patients that you look out for, or do you have any horror stories?
The horror story is the patient who checks yes on everything when they come in for the initial interview. Everything in the world is wrong with them. Or the patient whose husband handed me a laminated sheaf of papers. These were double-sided, 4 pages, which had all the patient's allergies listed. And the statement was, "Doctor, before we begin, let me just give you her allergies." And there was about 100 allergies on those. And while I was reading that, he said, "Oh, by the way, I forgot, we updated some." And he handed me 2 more papers.
So when you came to Texarkana, did you expect to make a change in the program? If so, how did you make a change?
Well, when I came to Texarkana, it was interesting. I came from a hospital with a lot of emphasis on stroke care, and over here things were somewhat prehistoric because a clot-busting drug, TPA, tissue plasminogen activator, had been approved in 1996, and when I came here it was 2003, yet even at that time people still had doubts. Oh really, we can use that for stroke? Yes, we can. And there was also an attitude about emphasizing the risks and minimizing the benefits in order not to have to use the medicine, because I think a lot of it was apprehension on part of the local doctors, and part of it may have been an unwillingness to change an easy way of practice. So when I came here it was interesting. I was told by a certain, not our hospital administrator, but a different hospital administrator, that Dr. Malik, you may be very highly trained, but we have to listen to the established neurologists. And since I was the new kid on the block, I said, does that mean old? So now I'm getting old, but at that time I wasn't, so it was fun. Normally we try to assess people for clot-busting drugs within minutes of arrival, yet initially the policy was being made that 90 minutes is a more reasonable time frame, and my comment to that was that Texarkana is so small that if you push on the gas hard enough, by the time your foot hits the floorboard, you're outside city limits. So it should not be the case. And I guess that didn't go over too well initially, but over a period of time, one hospital did work with me, and we did change the way things were done. I finally got them to realize, after we had a few successes, that actually the drug worked. My initial deal with them was that just call me and I'll take care of it. And most people here thought that I would not come, so, but I did. And after I had my first really massive stroke patient walk into the ER 3 weeks later and shake hands with the doctors who thought that he was going to die, I think that changed things. So that was fun, and it has been fun since. Around the same time, Texas wanted to come up with a system of stroke care, so I was invited to be on that committee, and we wrote the laws for how do stroke patients get triaged in the state of Texas. and our hospital became the second stroke center in the state. So it has been fun. We have won every award since that time that American Heart Association can give. So I think it has been a lot of fun, and seeing that even people who did not believe gradually and begrudgingly accept that things work if you do them right is rewarding. So,
could you explain how a stroke works, and are there different types of strokes, or how are they caused?
well, there are two major types of strokes. They're the kind in which there's a bleeding in the head, which is about 20%, and then there's about 80% where there's a clot. The ones with the bleeds usually end up being surgical, or some of them are. But the bigger number is the one where there's a blood clot, which is stopping the flow of blood. And when the blood doesn't flow into the brain, then that part of the brain gets damaged. And then the functions that that part of the brain carries out are damaged. So the goal is to try to restore the blood flow as quickly as possible. And there are many ways of doing it, but the most established method is by using a drug called TPA, tissue plasminogen activator, which is given over a period of an hour. The timeline for that is that the drug should be given within 3 to 4.5 hours of onset of symptoms. And the sooner you can do it, it doesn't mean you have to wait for 3 hours, it means you should get it done within 3, at the most 4.5. But the sooner you can give it, the better chances you have of having a resolution of the symptoms. It breaks up the blood clot, restores the flow.
Okay. Do you have an estimate of how many patients you've seen?
For acute strokes where we gave the clot busting drug?
Yes.
At Wadley Hospital, I think, since I've been here, the number must be close to around 500 to 600 patients.
Okay. In total, how many years have you been practicing?
Well, considering since I got out of residency, it would be 18 years. Now, of course, a couple of those years I worked as a VA staff physician and had a stroke fellowship, but I've been in Texarkana now for almost 14 years. Well, one of the fun things about being in a small town is that you can really actually make a change in the way things are done. Sometimes in bigger cities, the system becomes too cumbersome. Smaller towns, smaller hospitals are more nimble, they're more willing to work with you when they are willing to work with you. And you can make a change. So I think that you had asked me what to tell people who are aspiring medical students. One of the things I would say is that go to places where there are fewer people, and don't be afraid to go to small towns. Not everything is in the big cities, because sometimes the bigger change can be made in a smaller town.
What were your grades like during your undergraduate studies?
Well, they would be kind of hard to calibrate on an American system because we don't have a grade point average system. So I would consider most of them to be A's and maybe a high B somewhere.
Okay, well, for pre-med students who aren't doing well, do you have any advice?
If you really want to do this, you will manage it. Don't get too discouraged, because there will be things that you will study which technically you may need, but in real life, when you're actually treating real patients, unless you're in academic research, some of that stuff will not be necessary. So just the fact that you cannot get a biochemical pathway down does not necessarily mean that you can't be a good doctor. In fact, one of the finest doctors I know was a gentleman who was an average medical student. Yes, he had ended up being a great diagnostician because he knew when to ask the right question, and he knew, the best way I can describe it, it's that it ain't right. And that it ain't right you can't teach. You sometimes just have to know it. So if you have that, you'll do fine.
So I'm assuming that by the "it ain't right" you mean that that's one of the most important parts
Yes,
of being a doctor.
yes, because you should be willing to pick up on bad stuff happening. And, you know, in that particular situation, uh, some doctor who's extremely book smart, knows every chemical pathway known, may not be able to apply it. So, and sometimes you have to be willing to take a chance, willing to go the extra mile to do something different, and that's what makes you good.
So aside from those traits, what other traits would you say make good doctors?
Wanting to make a difference, wanting to help people live better. You can't really say necessarily live longer, but you have to really like your patients. And you really have to care about them, and you have to think of it this way, that when somebody really sick comes to you, whether that person, if that person was your family, how would you like to be treated? And I think that's what's important. You can't make people numbers, can't bring them down to relative value units or whatever that insurance companies and whatever else calculate how to pay us. It cannot be about the payment. It has to be wanting to make somebody better and have fun doing that. Besides, sometimes when you have to run to the hospital in a hurry with your flashers on and your kids in the car doing 90 miles an hour, that's kind of fun too.
Do you have any long-standing patients? I mean, what's the longest you've had a patient for?
I have some patients that have been with me since the day I came to Texarkana. So, some of our seizure patients who are very well controlled still come and see me every so often to get their medication refilled, get their labs checked. Some of our stroke patients we followed who did better, to make sure that we can reduce the risk for further strokes.
Are there any illnesses or problems that you see that you really can't do anything about? Are there any incurable issues?
There are genetic diseases, and it will probably take a long time to fix those. And of course, sometimes when people have anoxic brain injuries for whatever reason, they may have a heart attack and the heart stops beating, blood doesn't flow, the brain is deprived of oxygen, those people end up with long-term damage. So, and of course the strokes that don't get fixed. But really, I think the most frustrating ones for me are the anoxic brain injuries, because there's not a whole lot you can do. But you have to always remember that there may be some that you can't fix, and you have to know that. Yet you try your best to fix things as they come along.
This is kind of a crude question, but have you ever killed a patient? I've heard that every doctor kills a patient at some point.
You don't kill them on purpose,
Well,
but sometimes people do die.
Okay, well, I would like to thank you for interviewing with us today. And for the record, is it okay if I post this video and share it with my class?
Sure. Have fun.
Thank you.